Dr. Faiz. Today, the lecture going to be about the introduction to pediatric cardiology. So we're going to talk about the common cardio problem in children, the etiology, the pathophysio, what are the common clinical manifestation, what are the investigation that we send, and then the management of the respective problems. Okay. Alright, so cardio problem in children in pediatric population can be divided into two, which is first congenital, the problem that they are born with, then acquired, they have normal heart initially, but later on got developed problems. So we're gonna talk about a bit more later. Alright, so congenital heart defect basically is a structural problems from the abnormal formation of the heart and major blood vessels during fetal period. So during the embryo formation, there is some insult along the way, multifactorial, we don't know really the cause, so causing all this defect lah. Can be your heart, it can be other organ as well. So 3% of populations will have chances to have certain congenital defect lah, not just the heart. So this 3% we don't really know the cause. So this congenital heart problem is already existed since birth, and then it is the most common type of birth defect lah. And then the incidence about 8 out of 1,000 baby born life. Okay. Alright. So as I said earlier, it's a combination of genetic factors and also environmental factors. Some can be explained, like syndrome. The common syndrome, your trisomy 18, which is your Down syndrome. So Down syndrome will have their own set of heart problem, most commonly AVSD. Alright, there's also trisomy 13, trisomy I said 18 for Down syndrome, sorry, trisomy 21, trisomy 18 which is your Edward, trisomy 13 which is your Patau. So all these trisomy will have some sort of congenital heart defect. Some can be mild, some can be severe. Alright, Turner syndrome will have coarctation of aorta and also bicuspid aortic valve, so there is some aortic flow obstruction. Alright, if the patient have family history of congenital heart defect, like the mother has problem like ASD, tetralogy of Fallot, the chances of the offspring will be about 5%, so a bit higher than general population. If the sibling has congenital heart defect, so about 5% chances for the next sibling will have congenital heart defect. Okay, so certain drugs that mother take during the pregnancy can cause problem as well, like retinoic acid, anti-epileptic like benzodiazepine and lithium. Certain infection like rubella can cause congenital heart defect as well. If mother is alcoholic or taking alcohol during the first trimester, or if mother also smoking. And then most common quite common problem in Malaysian mothers is diabetes lah. So it can be established diabetes, it can be gestational diabetic mellitus. Okay, so it's very common problem in our pregnant mothers. So yeah, okay. So clinical manifestation of congenital heart defect can be breathing difficulties, so can be feeding problem, and can have poor weight gain, and they can present with murmur or cyanosis. So the breathing difficulties can be from the beginning, but if from the moment they are born, then they have breathing difficulties, you still have to rule out the lung problem as well, because lung still the first problem they can have before they have congenital heart problem. And then the feeding problems, if patient have feeding problem include interrupted feeding, and then because babies usually the only work they do is feed, pass motion and sleep, that's all. Okay, so they don't run yet everything, so feeding is basically the most work they do. So if the feeding, they have sweating during feeding, they have slow feeding, kalau they feed taking more than 15-20 minutes, half an hour, 45 minutes is very prolonged. Usual babies, they feed around 5 to 10 minutes. They can finish the feed already lah. So because of this feeding problem, they will have poor weight gain. Okay, so if poor weight gain, babies usually gain weight around 25 gram a day. So if you count the weight gain from the birth and then the weight gain during the follow-up, you have to count how many gram per day they gain. So if not enough, then you have to find out the cost lah. Alright, so this is usually they always come together lah. It's not just one problem. Alright, so cardiac murmur can be present at birth, can be present later. So it depends on the type of condition. Like tetralogy of Fallot will have murmur since birth because of the pulmonary stenosis, and then the murmur will be loud. But if VSD murmur, ASD murmur, they can present a bit later. The reason, there is explanation for it. Anyone knows why some murmur only present at 1 week of life, 1 month of life? Don't know? It has something to do with the pulmonary artery pressure.
Oh, because they were close by themselves.
Sorry?
Because they were close by themselves.
What close by the self?
Because of when the child is able to breathe,
Mm-hmm.
due to the increase in systemic pressure
Mm-hmm.
and drop in pulmonary pressure,
Yeah.
the hole close.
Okay, you are talking about probably PFO lah. Alright, but to explain why the murmur not present at birth is because pulmonary artery pressure is still very high. Because in utero, your fetal circulation, your right side pressure is always higher than your left side. Okay, so when baby breathing, they take their first breath, the pulmonary artery pressure will drop, but it doesn't drop immediately to normal. It will drop over time. So it will take about 1 week, 2 weeks, 1 month, depend on the baby and depend on the problem they have after the delivery. So when the pulmonary artery pressure drops, there will be left to right shunt. If no shunt, no murmur. Okay. Alright. So if the pressure on the left side and right side is the same, there will be no shunt. So no shunt across the defect lah. If got VSD for example, no shunt mean no murmur. Okay. So when the pulmonary artery pressure on the right side drops, your left pressure is higher than your right side, then you will have shunt, then the murmur will start to be present lah. That's why the common referral for murmur is always 1 week when they come for jaundice checkup, or during the routine 1 month examination, they refer to hospital for murmur lah. That's basically the explanation lah. So for simple defect like VSD, ASD, they always present like that lah. Okay. Alright, cyanosis at rest or on exertion. So in cardio problem, there are two main presentation. Either they present with heart failure or they present with cyanosis. Okay. So in patient present with heart failure, basically increased pulmonary artery circulation, mean left to right shunt, more blood flow to the lung. When your lung get flooded, then your heart failure comes. Alright. Why they present with cyanosis? Because there is less blood flow to the pulmonary circulation. So less blood flow, less oxygen to the lung, less oxygen return to the left side, patient more sinus lah. So in cardio patient, they either present with heart failure or cyanosis. Okay, so just remember that the key factor that determine whether patient got pulmonary artery flow increase or decrease because of some stenosis lah. Alright. Okay. So the diagnosis of congenital heart defect, so when they referred to hospital or to cardio patient, to the cardio unit, so they will do echo lah. So some are diagnosed from antenatally itself, like fetal echo. So the ONG will do their detailed scan. Once they do their detailed scan, then they noted the heart size probably abnormal, one side bigger or only can see one chamber instead of 4 chamber. Then they will refer for fetal echo lah. Then the Paed cardiologist that do fetal echo will screen and then come up with diagnosis. It is good to know antenatally because we can counsel the parent. One thing. Second thing, we can prepare for the delivery lah. So because you already know the diagnosis is kind of like 70-80% accurate. The remaining 20% because of the limited view from the antenatal echo. So when they prepare, so they can prepare better, so that everybody not urgent rushing because they don't know the diagnosis lah. Okay, so they can plan the diagnosis, you can prepare the medication beforehand. Okay. Secondly, we can do screening echo if patient is syndromic like Down syndrome. All the Down syndrome baby will need echocardiography. Doesn't matter lah got murmur or no murmur during the after the delivery. If patient have family history of congenital defect, like one of the sibling have congenital heart defect, we also will screen the siblings, or the sibling has history pass away because of congenital heart defect, we will give the appointment to the parent when the next child is born. Alright. So severe heart defect usually diagnosed at birth or within the first few months. So because when they diagnose at birth, usually they are sinus lah, because unable to saturate on air, and then need intubation, then we'll do the echo at the NICU itself. Alright, then the first few months, because about 2.5% infant will have some congenital heart defect if they present with murmur lah, that need intervention. Okay, so the less severe and mild defect can be incidental finding during the routine follow-up. If already in the pediatric age group, already toddler age group, if you hear the murmur, there could be multiple reasons of the murmur. Could be just hyperdynamic circulation because of anemia. It can be just innocent murmur, and then it's be less likely to have some defect lah if diagnosed a bit later, other than infancy punya period. Okay. Some defect like ASD may only be diagnosed when the lady already pregnant, because ASD is basically the most common congenital heart defect that I diagnosed during adulthood. Alright, VSD is the most common defect that I diagnosed during childhood. Okay. Alright, these are the common congenital heart defect as ASD, VSD, AVSD, the PDA, the tetralogy of Fallot, the coarctation of aorta, and TGA lah. So this is the common one. So it include your Acyanotic, then Cyanotic lah, which is your TOF and TGA. Coarctation is Acyanotic as well. Okay. Alright. Okay. So Acyanotic basically the shunt from left to right. So the left blood already oxygenated, so the mixing happen at the right side. So and then that's why it's called acyanotic lah, because the oxygenated blood get pumped to the rest of the body, so your expect to pick up will be normal lah. Alright, your SD, VSD, PDA, AVSD, and coarctation. So yeah, I'm not gonna explain any more about this. So yeah, basically left to right shunt will cause symptom of heart failure lah. So depends on the degree of the defect. Some small will not have any symptom except the murmur. Murmur is a sign. If it will not be any symptom, the child looks normal, there will be no signs of tachycardia, no signs of failure to thrive, no sign of interrupted feeding lah. Only we'll know from the examination. Okay, but those with large defect like VSD, they will have tachycardia, they will have tachypnea, they will have failure to thrive, interrupted feeding. As I said earlier, sweating on exertion or at rest. Wet cough because lung is flooded because of increased pulmonary blood flow. And because of lung is wet most of the time, is a medium for infection, so they will have recurrent lung infection. Yeah, they will present with cardiac murmur as well. Fatigue is a bit subjective, because sometimes child is very active, you probably cannot gauge the fatigue level lah. But once they are bigger, it's much easier lah to gauge the activity level, because we can ask the question like how many stairs they can climb, how far can they can walk from the school gate to the school class. Those are some example how to gauge the activity level lah. Alright, but in infant toddlers, yeah, you can say compared to their peers, maybe they're less active, they can stop the activity faster compared to their peers. Alright. Okay, so atrial septal defect. So basically your heart chambers, there are 4, right? Right atrium, left atrium, and there is your septum here, and then right ventricle, left ventricle. So the defect here we call ASD. So about 5 to 10%. The most common type is secundum. Secundum basically right in the middle lah. Okay, so primum is at the base of the heart. The base of the heart basically the floor in between atrium and ventricle lah. So if the defect is somewhere here, it's called primum. If the defect near to your vena cava, doesn't matter lah, IVC, inferior vena cava or superior vena cava, the defect will call sinus venosus lah. There also defect called fenestrated lah, mean there are multiple secundum. They will cause fenestrated lah. Then another type is coronary sinus lah. What is coronary sinus? No. Basically, it's a venous drainage of the heart lah. Alright, so coronary sinus will collect all the venous blood from your heart. Then they all be collected at coronary sinus, and then will drain to the right atrium lah. But sometimes that coronary sinus will have a defect at the ceiling, so they don't have the coronary sinus doesn't have a roof, so it will cause ASD as well. Okay, so the treatment is by device closure. So the device closure, the secundum is suitable for device closure. The primum is need surgery lah. Alright, okay. Another indication for surgical closure is because of the size lah. This baby is too small, less than 15 kilos, they will go for surgery as well. Alright, so yeah, ASD are usually asymptomatic. Most of the ASD will close. So if by 4 years old they still hasn't closed, then it will not close lah most of the time. So ASD less than 3 mm is called PFO, patent foramen ovale lah. So PFO basically tiny ASD lah. Okay. Alright, large ASD, those with more than 10 mm can cause congestive heart failure, but only about 10% lah. So 90% of ASD will not have any problem lah, because atrium is very low pressure chambers. So low pressure chamber, the shunt will be less compared to the VSD lah. So the size don't really matter lah. But if the large ASD remain untreated until they are 40s, 50, they will become isomenger as well lah. Okay, over time. So it's over time lah instead of short time. Okay. Alright, so VSD is the most common defect lah in pediatrics. So it can be here, it can be up here. So here we call muscular VSD. Here the membranous part we call membranous ASD lah, or perimembranous. There is defect also in between the valve, so we call doubly committed VSD. So there are many types. So the treatment is most of the time is surgeries, but the small VSD we don't really refer for surgery lah, because they have chances to close out, especially the muscle VSD. Okay, even the perimembranous VSD also can close spontaneously lah. So only the large one we will refer urgently for closure lah. So the large one will be determined by the failure symptoms lah. Okay. Alright. So if small, they will be asymptomatic, they will have normal growth. So you only need to follow them up once a year. If they are okay, make sure their teeth is good, no caries, because any congenital heart defect will have risk of infective endocarditis lah, and they all need SBE prophylaxis. SBE stand for subacute bacterial endocarditis lah. So anyone go for invasive dental procedures or any operation need SBE prophylaxis lah. Okay, ASD don't need, only VSD and the rest of the congenital heart defect lah. So moderate to large VSD will have heart failure during infancy. So the symptom as I already mentioned earlier. The large VSD also include your precordial bulge, your hyperdynamic precordium, and bilateral lung crepitation lah. So in peds, the heart failure don't really have edema, don't really have ascites lah. So don't really go look for it. Okay. Okay. AVSD. So AVSD is basically the most common defect in Down syndrome lah. So out of my 13 years working, only one AVSD or two AVSD that are not syndromic lah. Mean the rest are all Down syndrome. Okay. So basically the defect here at the inlet and then the floor of the heart lah, basically. So the valve, instead of two separate atrioventricular valve, they are only single atrioventricular valve. Okay, so basically no floor. Alright, so there are primum ASD up here and outlet VSD. There are two components of AVSD lah. So Down syndrome, 50% of it will have AVSD, the rest will have any other congenital heart defect, VSD, PDA. And then in Down syndrome also, the out of 50% will have severe congenital heart defect, mean need urgent surgery, and also need some also severe cannot do anything. Alright, okay, so next is PDA. PDA is a normal blood vessel lah. During antenatal, your PFO and PDA are present lah in babies that usually close within 1 week lah, because when there is oxygen, the PDA will be automatically close over time lah. But some babies, like premature babies, will have tendency for the ductus arteriosus to be patent. So it's a vascular structure at the proximal part of your descending aorta, and then to the roof of main pulmonary artery near the left pulmonary artery. Okay, so yeah, as I have mentioned, it's a common defect in premature. Patients are usually asymptomatic with small PDA. So large PDA also will cause heart failure symptoms. Okay, so on any left direction PDA, VSD will have heart failure symptom. Then they will have on echo left-sided chambers dilatation. Okay, for ASD will have right side chambers dilatation lah. Okay, why they are dilated left side? Because the volume will return to the left side lah. When it shunt at the PDA level, it go to the pulmonary artery and will go back to pulmonary vein, go back to your left atrium and left ventricle. So the volume, instead of going to the body, maybe 10-20% will go back to the heart. So it become about 120% lah total volume. So over time the wall gets stretched and we be dilated lah. Okay, it's only in moderate and large VSD or large PDA. For ASD, why right-sided dilated? Because the shunt left to right, then most of the blood, extra blood will remain on the right side kan, right atrium and right ventricle. Okay. Okay, so spontaneous closure are more likely in premature infant. So if term baby will have PDA, most likely they will need to be closed by device at some point if causing heart failure. If small PDA don't have any murmur, we will not close it. We only give follow up to monitor. Okay. So medical treatment in premature baby include your paracetamol and ibuprofen lah. Okay, so that's why patient mothers, pregnant mothers cannot take your NSAIDs, especially PCM still can. So because NSAIDs can cause premature closure of your ductus arteriosus. Okay, so if the PDA close prematurely, your right side will become high pressure lah, because there is no bypass from right to left, and the right side become very hypertrophic lah when at birth. Then patient baby will go into persistent pulmonary hypertension of newborn, PPHN. Okay, so treatment includes surgical ligation if too small, or occlusal device. But nowadays, even 1.5 kilo can go for device closure lah. We have very small device to close the PDA nowadays. Okay, so large PDA, if remain untreated, will cause pulmonary hypertension over time, same as any other defect that cause left direction. Alright, so coarctation basically the narrowing at the level of ascending aorta. It can be at the isthmus. Ascending is here. Isthmus is basically the top of the arch, and then your descending aorta lah. The most common one is basically at the descending aorta, post ductal lah, post PDA. Okay, so the small one will not cause any problem, but the big one will cause left side to become hypertrophic lah, dilated over time, and can cause heart failure also. This heart failure because of pressure overload rather than volume overload. Okay. So if the coag undetected since birth, they will cause they will have collaterals lah kalau the obstruction is quite severe. Then the symptoms basically other than heart failure, you can only detect it by doing for what? For coarctation, what can we do to check for any presence of coarctation?
Radio femoral.
That's one of the signs. Blood pressure, what can we do? Yeah, so you do 4 limb blood pressure lah. Okay, so there will be discrepancy lah. Alright. So it present about 8 to 10% of total congenital heart defect. Yeah, 30% Turner syndrome will have coarctation. Alright. Descending aorta supplied by PDA in earlier life. So if the coarctation is severe, PDA probably will close a bit later. But once PDA close, if the coarctation is severe enough, your lower limb, your distal organ will not be perfused once the PDA close. Then we cause hypoxic lah. Over time, lactic acidosis, the patient can come in a collapse state. So if newborn come in collapse state, one of the differential that you have to think about is coarctation on top of presumed sepsis or IEM lah, inborn error of metabolism. Okay, so that's why during your newborn screening we have to examine for what? Yeah, which during newborn screening you have to examine for what? To detect coarctation other than falling BP. Sorry, murmur? No, they will not murmur because the inside the heart there will be no defect. This is only obstruction at the vessel. So you examine for femoral pulse. Okay, but if femoral pulse is present, it does not mean patient doesn't have coarctation because PDA is still open. Okay, once the PDA close, then the intensity of femoral pulse will be less lah. Okay, but some are severe enough to be detected early lah. Okay. So sign and symptom: heart failure, significant difference between systolic BP and lower limb, difference of more than 20, absence or weak femoral pulse. Okay, this one very subjective lah. If you're not experienced enough to detect which one femoral pulses is normal, so it can be missed as well. So those missed, basically they will have systemic hypertension lah. So yang hypertension punya workup, you have to do the echo, look at the ASH, do the falling BPs lah. Alright. So how do we manage the acyanotic heart defect? Because they are most likely to have failure symptoms, so you manage the heart failure lah. So heart failure, how you manage? Basically medical and non-medical therapy lah. Non-medical therapy, you do what? If very bad, you give oxygen, and then you restrict the fluids, then you make sure enough nutrition. Okay, then the pharmacological, you give your anti-failure lah, your diuretics, furosemide, Spiro, your ACE inhibitor, which is your captopril or beta blocker lah. This is the one very severe. Okay, device for SD and PDA. VSD, some of the VSD can be closed by device as well. Then surgery lah for the rest. Okay. Alright, so cyanotic heart defect next. Basically, cyanotic heart defect, the most common one is your TOF. So what are the 4 components of TOF? Okay. Okay, so there are pulmonary stenosis, right ventricular hypertrophy, okay, aorta, and large VSD. Okay, so what caused the murmur? So why they don't have heart failure? I already explained earlier.
Because they have
Sorry?
because they have
No, why they don't have heart failure despite large VSD? What did I say earlier?
because they still have PTA.
No. what did I say earlier about how cardio patient present either heart murmur or cyanosis, right?
No shunting.
There is something, but the pulmonary artery circulation is protected. Protected by what?
Higher
By the pulmonary stenosis lah. Your pulmonary stenosis is the gatekeeper. Mean the blood cannot flow as much as possible because of PS. So PS will restrict the blood flow to the lung. Okay, so that's why TOF no heart failure. Okay, but the PS is severe enough, mean the flow is very minimal, they can cause cyanosis lah. So understand, despite the large VSD, why TOF don't have heart failure because of PS. So remember, the flow to the pulmonary circulation will determine how patient present. Okay, so TOF got PS, they will have cyanosis lah. But some of the PS is very mild, so some of the TOF may have heart failure lah. We call it pink TOF because there is PS, but the PS not so severe, so blood flow still a lot to the lung, so they will have certain degree of heart failure as well. Okay, alright. So why patient TOF ada RVH? Because of the PS lah, because pumping against the very high pressure. Okay, alright. Okay, TGA. So why TGA got cyanosis? Because of the transposition of the great arteries lah. Okay, so how do we keep patient alive?
Oxygen.
If this one simple TGA, I mean there is no ASD, there is no VSD. So how we keep patient alive? No, oxygen will not keep patient alive. Once the PDA close, once the PFO close, how patient to get oxygen? Because the circulation is in the closed loop, right? The right side remain on the right side, the left side remain on the left side.
There's no BT shunt.
Yes, BT shunt one of it lah. So but before you can arrange for BT shunt, the one you can give something straight away effective is your prostaglandin lah. Okay, so we start Prostin. Prostin is a brand name lah, the commonly used terminology here is prostaglandin lah. It keep your PDA open. Okay, so some of the other than giving prostaglandin, we also do BAS lah, BAS. We call it BAS or balloon atrial septostomy. So we make the SD bigger. Okay, so you need unrestricted flow. Okay, if got restricted flow, patient have metabolic acidosis, is not enough flow lah. Okay, so you need enough medicines to get oxygen circulated throughout the body. Okay, so only later they may go to BT shunt, or most of the time they go BT shunt lah. BT shunt for other problem lah, like TOF. If the PS very severe, they go for BT shunt. But for TGA, prostaglandin, straight away corrective surgery. Okay, but got TGA, VSD plus VSD. If VSD is big enough, don't need to do anything lah. But they will go into heart failure very fast lah. Still need early closure. Okay, alright. So this is the as I already mentioned many times, cyanotic congenital heart defect, cyanosis, clubbing, and polycythemia. Okay, why they cyanosis? Because of restricted blood flow to the pulmonary circulation. Why do they have polycythemia?
Because poor perfusion, the body produces so much of red blood cells.
So it's a compensatory mechanism lah. When your saturation 75, 85 in the chronic state, your body will produce more hemoglobin to carry oxygen to the body lah. So because they produce more hemoglobin, they will have what deficient? Iron. So on top of it, they will have iron deficiency lah. Even though the hemoglobin is normal, when you check the iron, it will be low. Okay, so you probably need to supplement a bit as well. Okay, so cyanotic heart disease also will have two pulmonary artery circulation lah. Some pulmonary circulation will increase, like your TGA, truncus, and TAPVR, total anomalous pulmonary venous drainage lah, or return. Those will decrease pulmonary circulation, like your TOF or tricuspid atresia. So one will be cyanose, very sinus. One is sinus with heart failure. Okay. Alright, so TOF basically during the embryology phase there is anterior deviation of infundibulum causing the PS lah. So 4 features as you already mentioned earlier: large VSD, overriding aorta, RVH and PS. PS can be at the valve level, below valve level or above valve level lah. Okay. Alright, so RVH, large VSD, PS and overriding aorta. So overriding aorta must be about 50% lah. If 75%, 100% cannot be tough already. It's called double outlet right ventricle lah. It's a bit different. Alright, that one we need to know. Okay, so 5 to 10% congenital heart defect, most common congenital cyanotic heart defect. So it's a spectrum. As I said earlier, some the PS is not so bad, will be pink TOF. Those PS is moderate enough or severe enough, is called blue TOF. Okay. So cyanosis is due to the severe obstruction of the right ventricular outflow. Pink TOF due to mild obstruction. So complication: if patient have very severe flow obstruction to the pulmonary artery, they will have cyanosis spell, and then your RVOT can also spasm. They become spasm. So if patient unwell, they will have become the pulmonary stenosis will become even smaller. If patient diarrhea, dehydration, less venous return to the right side, less blood flow to the lung, they will become more sinus lah. Okay. So cerebral abscess, why it happen? Because less blood flow to the lung. At the lung, they will do like your Coway filter. They filter out all those bacteria at the capillary level. So because there is no filter, more bacteria will go to the left side, and then there will more bacteria seeding in the brain. Over time, they will become abscess lah. Okay. So the treatment basically surgical correction. If not big enough, they will go for BT shunt first. Okay. Or some will go for PDA stent. Alright. Okay. So they are quite comfortable and pink and thriving initially. But when the cyanosis is severe, or when they go to 6 months, 7 months, 8 months, because of cyanosis, the cyanosis also can affect the growth later on. Okay. Cyanosis failure to thrive cardiac murmur in the blue TOF. Okay. So pink TOF can have heart failure as well. So may present with cyanotic spell, desaturation, severe cyanosis, and then during agitation and stress. Okay. So this is the boot shape. So how do we know patient have boot shape?
And large mediastinum.
Okay, narrow mediastinum here.
Oh, yeah.
So what does it say here? Updated or hard apex. Okay, you see the apex here. So to qualify as a boot shape, when there is a boot shape, basically there is right ventricular hypertrophy. Okay, so when there is hypertrophy, it will uplift your apex. So you see your apex is up here. Nampak tak? Apex should be down here at the diaphragm. Okay. If you see the chest X-ray, looks like boot, you see the apex first. First the apex. So apex at the diaphragm is not boot shape, even though it looks like a boot. Okay. Because some X-ray do like looks like a boot, but it doesn't mean patient have RVH lah. Okay. So the main thing is the apex, and then oligemic lung field. Alright. Okay, TGA, the parallel circulation may have ASD, VSD or PDA, present early after birth with cyanosis lah. So requiring surgical treatment. Alright. So definitive treatment basically just switch the arteries. Alright. Okay. Sounds simple lah, but it's not that simple. Alright. Okay, so for TGA, basically egg on a string. This one not very typical lah. Look like an egg. Some egg look like horizontally lying. This one almost like vertically lying. Alright. So oligemic plethoric lung field lah because of the increased pulmonary flow circulation. Alright. Alright. So sequelae, they can have heart failure, arrhythmias, like Epstein anomaly, because of the right atrium hypertrophy, your right atrium will have what? SA nodes, right? And AV node. So when you stretch your SA node, AV node can cause SVT lah. So Epstein anomaly will have SVT quite common. Those with corrected defect like VSD, because your VSD and Purkinje of fibers run next to each other. When they suture the area, it might suture the fiber as well, so they will have heart block as well lah. Some heart block is temporary. If 2 weeks post-op they still have heart block, it's become permanent already. Okay, so if uncorrected left to right shunt, last shunt increase pulmonary blood flow, over time there will be pulmonary hypertension. So if large VSD is not corrected by 3 months, 4 months of age, they will become pulmonary hypertension lah. So you miss the boat, you cannot operate already. Okay, surgical related complication, it can be pericardial effusion, can be pleural effusion, can be chylothorax. Okay, can be diaphragmatic paralysis lah. Your diaphragm paralyzed because they cut the phrenic nerve as well. Okay, it's because it's not easy to identify all those fracture lah and drop, right?